Thank you, Dr. Namrata, accommodating me in between. I am supposed to talk this talk tomorrow. Due to unavoidable circumstance, I am traveling today night back.
So
So Dr. Namrata wanted me to.
Dr. Kudlu is Medical Director, Prasad Netrale, Super Speciality Eye Hospital at Udupi, Mangalore, Sulia and Triathali, and also the editor proceedings for AIOS and President-elect for Karnataka Ophthalmic Society.
Thank you, Madam. In fact, Madam wanted me to talk on about the learning curve in SMILE because almost for another 1 year, at least more than 25 doctors are applied for training for SMILE training. So whether whatever the procedure previously people are hesitating, now everybody wants to learn this technique. So I thought, let me showcase this so that more and more people learn this, because most of the machines nowadays comes in the similar kind of platform. So I don't have financial disclosure for this particular talk. So I'll be just showing you exact, straight away go to the treatment part. So normally as a surgeon, I myself sit with the patient how exactly he has to be on the table. Once explaining to the patient, then each step in SMILE surgery is very, very important. Even optimal application of the anesthetic drop is also so important. If you put a more anesthetic drop, sometime it may loosen the epithelium. Always parameters has to be checked by the surgeon himself. Once I check, then I go for the next setting, make sure that the machine will start calibrating for that particular patient. Once it start calibrating for the particular patient, next is proper draping and even application of the speculum is also very, very important. Make sure that you will have a very wide opening while doing the surgery. Make sure that there is no eyelashes coming on the way. So adequate wash of the ocular surface and fornix is also very, very important. So give a proper wash. Make sure that conjunctiva is dry but cornea is semi-moist. Once again, it depending upon the each patient. Sometimes you may have to keep both this one is dry only. Head positioning is also very, very important. Patient with a longer nose, chances of suction loss, or you may not dock. Such cases you may have to tilt the head towards opposite side. Connecting and selecting the appropriate size cone is also very, very important. Even small step what I am doing so crucial for the success of the surgery. Always you plug it properly into the machine. For right eye, hold the cone in the right hand, go to the slot, lift a bit, you will hear a click noise. Once you hear the click noise, then machine will start calibrating for that particular cone. Patient with a white to white lesser than 12 mm, always go for a smaller size cone, do only 80 to 90% applanation. If the white to white more than 12 mm, go for a medium size cone where you have to do a 100% applanation. Once this is over, then you machine start treating. First you start with the lenticule cut, then with the side cut, then it will comes with the cap cut. Once the cap cut over, then with the incision. Normally beginners, I always tell them to put a 4 mm incision. So now next step is get the patient underneath the microscope. Identifying the right plane is very, very important. First you identify the anterior plane. Once you identify the anterior plane, now go and search for the posterior plane and just keep little bit dissection and keep it ready. Now turn the dissector, go for the longer end of the dissector, try to dissect the anterior plane, something called something like a windshield wiper movement. Try to dissect it completely, no, don't make irregular movements. Once your dissection of anterior plane is over, wherever you are open this posterior plane, you start dissecting. When you are dissecting the posterior plane, make sure that you dissect either side equally, otherwise you may land up with sometime lenticule may fold and to come to the one side. Once your proper dissection over, now then you can take out the lenticule, you can put it over the cornea and see for the integrity of the lenticule. So I will be just showing you few of the common complications of SMILE. First, I think probably most of us scared of the suction loss, but it is which has been come down. But even with the Visumax 500, whatever the instruction, if you take care, I think the chance of suction loss is very less. But this is a case patient very uncooperative. We could be able to see suction loss has been happened. Suppose suction loss happened during the lenticule cut, you can convert into the femtolasic in that moment only. Suppose if the suction loss happened during the any other step, then I think you like side cut, cap cut or incision, then you can go back to the machine setting. With the same setting only you can do, or you can even reduce the diameter by 0.5. Then you can straight away, you can recenter after the suction, Then also you can clear the bubbles from the center for the cornea and also wipe the undersurface of the contact lens. Then immediately you redock it. Machine will do the treatment in the same plane where it has stopped. Such a excellent technology. Few tricky situation I am showing here. One of the most tricky situation is the retained lenticule. Normally, if you keep all the parameters nice, normally treatment will be done perfectly by the machine. So here I have trained more than 100 doctors in and around the world. There's a few of the complication I am showing few of my good friends. So here first initial identification of the layer was done properly, perfectly by the surgeon. But while he turned his longer end of the dissector, while going to the posterior plane, you could able to see that his dissection, you could able to see there is a torn lenticule. But he was very confident. I told him to remove the lenticule. Then I told him, you take out the lenticule, you put it over the cornea. Once he has put it over the cornea, then he could able to see there is only half the lenticule is there. He can see that there is a area of torn lenticule. So then I immediately took over this case. I put this torn lenticule in the conjunctival sac. So how to manage it? So you can, some of them not well versed with how to identify. You can even use a triamcinolone acetate also. In this case, I just to do a fine focus with the microscope. Wherever the other part of the lenticule adherent, then I went with the longer dissector. Try to dissect. When you're doing this, the small lenticule, you have to be very careful. Minimum dissection. Go with the micro forceps. Hold. Try to remove as if you are doing something called in cataract surgery reverse rhexis. You take out that lenticule very slowly, put it over the cornea. Then whatever the lenticule is remaining in the conjunctival sac, I pulled it back and I joined. Now I could able to see a perfect lenticule is there. That means your dissection is perfect. So how to avoid it? Normally thin lenticule have a higher risk of tear during the dissection. Keep the lenticle thickness more than 50 micron in the lesser power. Dissection has to be always gentle. There is one more complication I am just showing you, that is lenticule on the flap. Again, the treatment has done perfectly well, absolutely, except for few of the OBLs. Identifying the layers also perfect. But when you are going with the longer end, suddenly sometimes surgeons will go inside the different plane. Always you should remember that if your dissection is very smooth, that means you are in the posterior plane. Surgeons like the genius like Professor Tityal sitting here, I think they can go to any plane and can take out this lenticule very easily. But I am just showing you in the interest of the beginners. Normally in this dissection you could do what went wrong. Normally he was very hesitating doing the dissection, and he has done a multiple entries in the interface during the dissection. So how to manage? It's very simple. Once again, go back to your shorter end of the dissector. Try to scratch the underneath the cap. Once you are scratching the underneath the cap, then slowly this lenticule will open up from the cap side. Once you are started opening, then I think you know that you are initially you are done with the posterior plane. Try to scratch some more so that you will have a nice grip. Then you can go with the longer end. You can go in between this interface and can dissect it out. Or someone, those are well versed with the forceps also, they can go with the micro forceps and try to take out this lenticule quite easily. So go with the micro forceps. Don't try to pull towards the wound. Rather you go towards the 6 o'clock, as I have told before, that you have to go towards the 6 o'clock. Something you are doing like a reverse capsular axis, and take out the lenticule and put it over the cornea. Make sure that it's round. So points to remember: always identify the anterior and posterior plane correctly. Always anterior plane has to be dissected completely first, followed by posterior plane. Always multiple entries into the interface can avoid this complication. So this is the last complication I am showing, especially I think most of us, if they keep cornea too dry, you can see there are a lot of black spots on the cornea. This is something nightmare for any of the surgeons. So such cases, I think these are the areas, nothing but the untreated area. Normally you may have a difficult dissection in such cases. So always you have to keep your mind cool. Try to dissect the cornea very slowly. So always in this case identify the plane correctly. Gentle but firm tissue by tissue dissection. So what I am doing, wherever there is a dark spot, there you can have a very rigid places. Go with the very tissue by with the smooth movement so that you will dissect that area. Once your dissection is over, don't try to push so much. You can use the forceps. Then when you are using the forceps also, always wherever it is adherent, go, hold, try to remove from wherever it is adhering. You can release your grip wherever it is adhering. That part you can go and catch the lenticule. Make sure that you remove the lenticule in the exact position. So once it is over, I think you can see in this case with a lot of difficulty, you could be able to remove the lenticule so successfully. So how to avoid? Always keep the conjunctiva and fornix dry, and cornea has to be semi-moist. Always avoid excess of applanation. When you are taking with the smaller size cone, always 80 to 90% applanation is more than sufficient. If the black spots are extensive, I think you can even plan for a surface ablation or LASIK later on. So take home message is always pay attention to the finer points that helps to make the patient smile. Once again, I thank Namrata madam for this opportunity. My guru Tityal sir is there, everybody. Thank you and all. One or two word about the Ajanta Pharma. I think it's so pleasure to be part of this meeting. I have been, I think, with the company almost around 22 years. One thing I always should appreciate about Ajanta Pharma is this is the one company always they introduce the product first time in India. Any product first they launch, then all other company follow. I think for this, I think we should give a hats off to them, getting a fantastic technology to India. Once again, I thank for this wonderful opportunity. Thank you, Ananda.
Especially looking into an initiation into smile. And beautifully shown videos, sometimes difficult to show these complications and how to resolve those are the critical point for learning curve as such. Because we are going to have difficulties mainly when you are beginning with these surgeries. As soon as you cross around 50 or 100 eyes, you become very, very comfortable in this particular procedure. And not a very difficult procedure, and it can be learned very fast, effectively also. And we know that non-flap surgeries are going to be the future in refractive surgery. The people have to learn this and acquire the technology and the system.